Okay.
Newton's a moderator.
Let's start with junior.
It is about 80, 80 and 90, 80 to 90. I'm not so sure about the quality of the ECG, but the voltage seems a little bit low, and the ABR, B1 is positive, B1 is positive, and the trim.
You can go to the front. You don't have to sit there. Okay. You can wander around. You can look at the fast angle ECG. Yeah, it's a good thing. You don't want to sit there.
You can use your finger.
It's you know, this is a free open session, so you don't need to be strict about it. We love to hear about your, comment and thinking.
You will be the participant of ECG Golden Bell in HRS. Good chance to practice.
But I can tell you that those EKGs are not difficult like this. Okay.
One is isoelectric, not so positive, and the 2, 3 positive. ADR is positive, ABL, and ABF is negative. So
Okay, let's start from the rhythm strip. How's the heart rate?
She told already 80s, 90s.
Okay, and the regular or irregular? Irregular. And each the QRS morphology same or different? Different. Okay. Are you sure?
Yeah, it is different. I mean, you're talking duration and then in terms.
And
Look at the lead one.
each QRS complex are preceded by P wave or not?
no.
No?
No?
Why not?
Oh, very unexpected. Unpredictable.
So as you said, I think you point out a very important thing there. EKG quality is not that great. Okay. And then, if you think about it, how long does it take you get a good 12 ECG when you do lead zone, all that? How long patient cannot move around quietly? What's acquisition time, modern ECG? Have you thought about that? That itself is important. Okay. Has to have a reason why the baseline ECG, certain portion is normal, certain is not normal. Maybe that reflects the patient's condition. This patient very critically sick, or guy is a loss of conscious, is not collaborating with you. Okay. So this is, but however, if you look at the beginning of ECG, end of ECG, quality get worse. Center is reasonably okay, but not the best, as you said. I agree with it. It's a very, very good comment. And then Dr. Park asked you whether there is any P wave. If you look at the low bottom lead one rhythm strip, look at the mid 5 complex, let's say. There's a clearly distinctive P wave that precedes QRS complex. Okay. So there's a probably P wave, atrial activity leading ventricular activity. Now, trying to comment your P wave. P wave, you know, this is very difficult to guess. Is why? Here the amplitude is low. But if you look at the other lead, all low. So global reduction of atrial electric activity. That's a conclusion you can draw. PR interval, upper limit normal. But if you look carefully, they're not stable. So AV nodal conduction is changing a little bit, but that could be physiologic too. But when you go to the QRS complex, how does this complex look like? It looks bizarre. It's not a normal looking QRS complex. Describe to me what you see. So I'm trying to teach you how to read the equation sequence. Okay, look at the global quality of ECG. Is there any noise that is a consistent pattern to it? Yes or no? And then look at the P waves and then AV interval, not going to the QRS complex. Okay, you take over from there. What do you see QRS complex? First thing, what's the quality of a QRS? Is it good or bad?
3 to 6
Mm-hmm. But then what else do you see? QRS amplitude, something wrong. If you look at the normal 12 ECG, limb lead 1 to 3, amplitude versus precordia, V1 to V6. Usually, which one is the taller? Precordia lead, because they are modified unipolar. And lead 1 to 3, usually bipolar. But this patient is what? Everything low. So now you got a conclusion. Oh, patient got low amplitude P wave, low amplitude QRS global. What else do you see? This heart doing what? It's not squeezing as we like to see. Okay? So you have to have some deductive idea when you see things. Try to create a clinical scenario where you can see this patient, atrial ventricle is down. Very, very sick, right? You got global failure. What else can be worse than this? Yet, what do you see? You don't see. How about ST wave? Do you see it? You cannot discern whether the ST segment was a T wave is this patient. And then next thing you look for, QT interval, short or long? You cannot tell precisely how, whether T wave, U wave, none of this exists here. So therefore, all merge together. So then when do you think that this type of a bizarre looking ECG happened? But there's one thing I want to point out so you think about it. AVR, V1, S segment is elevated.
Yeah.
Rest is all down. What that mean? Think about it now. When that would happen in ECG? I mean, if you say that the V1 is the S segment is depressed, then you may say, oh, it's a posterior infarction, right? What you learn. But then when it's segmental, this is not. This whole thing is like that.
Left main disease.
Oh, entire cardiac hyperperfusion could do that. Okay? Because your inferior lead also depressed, precordially depressed, whole thing is depressed. So maybe triggering event could be whatever, left main disease, something like that. But the consequence and the result is not. Show you global hyperperfusion, very sick heart. So this is a EKG. That much I can tell you. But one more thing is a very, very, what I would say, bad news. What is that? What is the first complex you see in ECG? That's a normal sinus rhythm or some different rhythm coming through? Because the noise you could not interpret 100% sure. But what do you think about that QRS complex? Little bit different than other. Perhaps that is originating from other chamber, ventricular PVC. So what that is eminent of what? If you have such a sick heart, you have a PVC. Look at the S segment T wave, much more elevated, much more ominous sign. This is a scenario where most likely patient go to cardiac arrest, BF arrest. Okay, so those things you can try to look into and then try to get enlightened.
One thing I would like to add, another unusual finding is if this patient is critically ill condition, generally the hyperadrenal status and the heart rate should be fast, but it is relatively normal rate. So
Not
we can
necessarily,
see-
yeah, not always that
we
happens.
can use somebody sedate this patient, or it is really sick
Yeah,
just before dying.
right. If you have a, let's say that non-electrophysiologic condition, not directly related to the heart, let's say that your pH, potassium levels alters in just that setting, then that can blunt autonomic response of the sinus node. Okay? So as the Dr. Fox says, could it be because of whatever underlying issue, but also could it be, as I said, a severely ill patient? So that would be more favorable to that. So let's assume that you got global hyperkalemia plus acidosis. So just so I want to remind you, if your pH drop less than 7.15, no pacemaker works. Doesn't matter, even you stick a temporary pacemaker, you put 1,000-volt energy into it, heart and not going to be able to stimulate. That's why we care so much about the pH during the cardiac resuscitation. Okay, so it is important to think about those things. And this patient QT was not long. You expect to see very long QT. A sick patient didn't. It's short. So what are the conditions that you can shorten QT? Hyperkalemia, right? Acidosis. Those things can shorten. So then you can all what you learn at school, you can start putting together this thing and then figure out. These are the rational thinking that we're gonna go through. Okay? Any other comment do you have? So when you see AVR, a segment elevated like this, usually the bad news. This is really bad. That's sick patient. And then you can tell where the QRS, where the T wave start, all of this is merging together on top of that PVC. Any other comment? Anybody else want to do this? We gotta go to senior level now. Okay. Anyone please add a comment? No.
그래도 얘기 좀 하라.
아.
No comment이야.
그냥
지금 근데 이 심전도가 ECG 캘리브레이션이 좀 잘못된 심전도가 아닌가 싶은데 모양이 조금 볼티지가 이게 10mm에 1mV가 아닌 것 같습니다.
Who is talking?
저 단국대에 있는 지금 김준태라고 합니다.
안녕하십니까.
예.
So you're talking speaker, so we have to introduce yourself. I'm sorry. But look at the caliber, first signal calibration, ECG, just before the first computer. Do you see that? Calibration marker?
마우스로 좀 짚어줘.
Do you see it? Yeah, that's a calibration marker. Is that not the standard? Huh? What do you think? You asked that question, I'm asking you now. How about that caliber marker? Is not that normal? He's not answering, so.
근데 그 10mV에 지금 5mV에 5mV라고 밑에도 코멘트가 있고 박스 모양도 저게 스탠다드한 모양이 아닌 것 같아서 어떻게 생각하시는지 박사님.
So if you do calibration, this is not so let's say how many people think this is abnormal calibration? That means you guys not paying too much attention when you do ECG.
다음 ECG도 똑같아요. 어떻게 돼 있어요?
똑같잖아. No, same level.
근데
Yes.
김준태 선생 같은데?
네.
Now you change your mind?
제가 알기로는 이게 한번 이렇게 턱이 지면은 이게 2배든지 0.5배든지 이게 바뀌는 걸로 알고 있었는데 이게 심전도 기계마다 조금 다른 것 같습니다.
그래서 스탠더드 캘리브레이션을 매주 처음에부터 리코딩 하는 거예요. Okay? So,
예.
rule of thumb, 2 big box is one calibration. Okay? 맞아? Close enough? Okay. All right. Anything else? That's a good comment, by the way. It's a good thing. Yes. Keep putting the questions. We always need all these questions. Anything else? I'm surprised nobody's commenting. Have you seen initial Q complex in normal ECG, this patient? Normally we have sometimes lead to 2-3 AVF, initial small Q, well, less than 140 millisecond box, and then R rate, right? This patient has almost no Q with anyone except B2, which is abnormal. B2 has a small Q initially. Okay, that's pathologic Q. It's not a normal Q. Rest you don't have it. What does that mean? Why you would lose a Q wave in the surface ECG? What's a Q mean first 40 millisecond 12 ECG? It is proximal septal ventricular activation, right? This patient doesn't have that vector. What does that mean? This patient has a septal hyperperfusion or the ischemic. Like that's why Dr. Bach raised a question: is it left main disease or not? Right? So it is something that when septal Q is absent in associated with such a bizarre abnormal ECG, always think it is involved at least left coronary system, least. More than that, perhaps most likely, but that's one of the events. So it is that important to notice that. Those are important is why first septal perforator, when you blocks what develop, a lot of patients, sometimes DF arrest, heart block, many other things can happen. Then you start thinking, if I'm gonna put a temporary wire, you get heart block, where are you gonna put? Don't put on the septum, you're not gonna be able to capture what that means. So EKG tell you a lot of story about the patient, okay? So I'm just giving you over the year, my experience to what is it, my experience, complications, so on. So when you're putting heart block patient, look at the ECG, make sure there's no septal Q wave, then you don't want to put it in there. You may want to put an apex or lower, okay? These are practical things we are talking here. Anything else we want to add?
네, 들리시나요?
예, 들립니다.
네, 보니까, 네, 저는 좀 특이한 게,
Who is this?
저 김미입니다. 네, QRS 보면, 처음에 ventricular activation, depolarization, repolarization 모두 다 되게 slugish하게 되거든요.
Right.
네, 저는 그래서 확실히 electron imbalance 또는 처음에는 상당히 아미오다론을 많이 써본 듯한 그런 심정이라 느꼈는데, 확실히 특히나 디폴보다는 리폴라리제이션 쪽이 많이 프롤롱게이션 돼 있어서 만약 그 약제 유발성이나 그런 쪽도 많이 좀 의심을 해봐야 되는 심정은 아닌가 생각이 들었습니다.
It is certainly possible EKG on the drug, but if you give amiodarone, what happens with the QT?
또 늘어나게 됩니다.
Why? Is the QT long to you? There's no segment this patient. It's like a T wave straight coming up.
길고 짧고 이렇게 좀
Right.
보여가지고,
It is possible that patient may receive maybe this patient has a cardiac arrest. They given the amiodarone drug. However, amiodarone effect usually manifests when you bolus it, amiodarone, you would see EKG change right away.
아니요, 바로는 안.
No, doesn't. So sometimes because of circulatory issue, many other issue, first of all, drug may not even get to the heart. So many other issues are there. So usually you will see peak manifest in ECG if you give IV amiodarone infusion 30-40 minutes later, not right away. There's one drug that I can see right away effective, as far as I know, is a mexilatin, lidocaine. So it is something that is a pharmacodynamics. But anyway, your thinking is appreciated. We start thinking about that. Okay.
It is very hard to determine the QT interval
Right,
with
that's
this
it, yeah.
ECG. However, if you look at the before, one QT is long, the other one is short.
Short.
Is there any possibility of repolarization alternate?
You can see that also in rhythm. That's why QRS duration is varying. You see that?
Yeah.
Look at the V1, lead one QRS duration. Yeah. Longer, shorter. Then start getting longer again. You see this? Do you see in the V1, the bottom strip? You agree that the QRS segment duration changed? Therefore,
미드 2에 보면 잘 보이는 것 같습니다.
right.
쭉
That
내리시면
excludes
네.
your drug issue. Okay, medication doesn't do that. And then you said the heart rate was irregular, right? What happened? When slower heart rate, QRS get wider. Heart rate speed up, narrower. Also QT gets shorter. So this patient has what? Probably brain hyperperfusion as well. Severe autonomic abnormality also present. So that's why you see several T wave, bradycardia, all that stuff when you have a stroke, right? So you can see that during the acute brain dysfunction, hyperperfusion, things like that. But this patient probably had a cardiac arrest and shock. So all that stuff happened. Have not stabilized yet. So tell us what happened. The resuscitation was successful.
Next slide.
Next slide. Now you can see what I'm talking. Look at the limb bleed, precordial lead difference. Okay. So important to memorize the normal ECG first. Read the normal ECG first. Now you guys can read. Who's gonna read this ECG now? 30 minutes later. Oh, somebody did a good job. Wonderful.
준영, okay?
기다려 그냥 자동으로. 크게 얘기하세요. 여기 마이크가 여기서 안 들려.
This is partial emphasis more and the segment at the area is now increased.
What you say?
Before ECG there was a Kuwait. Before
What is Q-wave?
QA.
Q-wave where? Which lead?
change it. Before there was a before was a Kuwait. B2.
B2.
Now become out. Is what you're saying. So tell me about the, how do you say patient has a low amplitude ECG? What criteria do you use when we read the ECG? Usually you should read the low amplitude in bipolar leads, not in precordial leads. Okay. So look at the lead 1 to 3. What do you think about this QRS complex? Is the amplitude is normal? It's very small?
Very low.
No.
Right.
No.
And do you expect such a big P wave? Somebody has such a small amplitude R rate? There's discrepancy here. Look at the P wave, almost big as QRS. Is this normal? No. This is we agree is a sinus, right? Because the lead 2 has a tallest P wave. Agree? Because sinus rhythm definition, if you don't know, read it. Is important. Activation of a sinus is initially inferiorly posteriorly. Therefore, lead 2 has to be positive. And then usually they're tallest amplitude. Even though there's a wide range of P wave axis variation depending on sinus rhythm origin. But the lead 2 in general, they are more positive and then they are highest. So this is sinus, most likely. Yet P and QRS proportionality is very much disproportional. Okay? So therefore you can read this ECG, low amplitude QRS complex ECG. What does that mean to you? Usually ventricular myocardial mass loss, right? But this patient has looks like all pretty much lost. So what is that? Global myocardial function loss. That's what you get concluded here. Now, next thing is take a look at the SDT wave and change. What do you think about this now? So you know now P wave is big. Okay, QRS is down. S segment also depressed still a little bit. T wave is inversion. QT is now long.
Oh,
Yes. So now it's the opposite direction we are heading. But patient has nice sinus rhythm. That's great. What does that P QRS dispersion mean? Maybe P wave should be smaller as well, but it got bigger when they have atrial overload. Can do that. So imagine a circumstance where ventricle doesn't move very well, atrium is fully loaded. That means patient maybe have a severe LV biventricular dysfunction. Function is down. And then also in part because S segment changes, right? Now it's AVL, S segment. What do you think? Elevated down? This is AVL.
looks like fractionated.
Yeah, and there are two possibilities here. Because S segment looks like elevated because it truly diseased, or PR segment is down because the patient may have a pericarditis, something like that. But the PR segment is not down any other area. So this got to be S segment is elevated that area in particular. AVR is also slightly elevated. B1 is slightly elevated as well. Okay. So B1, AVR, all that is what? Come from what territory? But what if this was a myocardial infarction? Circumflex, lateral, and then B1 is a precordial. And then maybe anti-left coronary system. This is.
Although Dr. Joe did not let us know the detailed history,
No, not yet.
but if this patient suffered from the cardiac arrest, we need to think about what is the predisposing factors in this space in this issue. Number one, cardiomyopathy, as Dr. Huang already mentioned. But if you look at the B1, it looks like the Brugada pattern, and the QT prolongation also can contribute to the cardiac arrest. So still we have many different diagnoses.
But the B1, B2 normal R wave is not present almost. And then AVR is elevated. So you can differentiate the diagnosis standpoint. You can raise a question whether this patient has acute myocardial infarction involving left system, the so-called so on. So this is acute ischemic. But usually, even though acute ischemic, you would not lose limb lead RA complex that drastic. Okay. So
Already 8-5.
okay.
Let us know.
So
Clarify.
what happened? Yeah,
Oh,
young female.
he was 29.
She was in our hospital cardiac arrest. Initial reading was asystole. At 5 a.m., patient fell down on the road. Somebody observed her and
Wow.
called 119. The patient transferred to Service Hospital in CPR. This is CPR flow sheet at 5 a.m. Initial reading was asystole, and after 4 times cardioversion, within change it to asystole and continue chest compression. But she arrived at 5:36 a.m. and after 3 times cardioversion and chest compression, she resuscitated at 10 a.m. And in review of system, there's nothing. And family story, no sudden cardiac death history. This is initial chest X-ray. There's no cardiomegaly and bilateral pulmonary infiltration. You can see. There is intubated tissue.
The patient has a basically over-penetrated chest X-ray, right? When you guys read the EKG, chest X-ray, you need to learn how to read it as well, right? It's over-penetrated chest X-ray. So you're gonna operation under vasculature. Patient has a flushing pulmonary edema. Look at that. Mesh kind of ground all around. So when you run radiology chest X-ray, what do you learn? 1/3 peripheral chest field should be black. This is a gray color. And then you can almost appreciate that floppy pulmonary congestion all the way to the periphery. This is a massive pulmonary edema.
What does it mean the over-penetrated chest X-ray?
You penetrate too much radiation dosage.
Too
Therefore, right, they wipe out everything, become white. Okay, after penetrate, become more black. Okay, that's what that means. So I know emergency very hard to do. They put a portable chest X-ray providing pretty quick, but it's still. So this has to be a acute event because the cardiac size is even the compression fairly long, not that big. You can see if a patient has a big cardiomegaly, then you do argue chronic cardiomyopathy, something like that. But this is a normal patient on the cardiovascular. Relatively skinny too. Okay.
Initial ABG was
Oh boy.
severe,
Close by.
severe
Ah.
acidosis and
But she was down a long time.
So, and rapid was 9.4.
Oh boy. That's
And in CBC, there's no specific findings. In chemical test, there's no specific finding except cardiac enzyme mildly elevated.
too bad.
This is
This is the patient I remember now.
this interest.
This guy taught me. Okay, that makes sense.
As you can see, myocardial function is low, about 25%. Is in the motion. Anterior and posterior was belonging to left atrium and mild mitral regurgitation. Can see the 3 chambers. Let's see more. This is interesting motion in lateral wall.
Can you specify the
Systolic phase. It was was below. So one motion going upward.
계속 러닝 좀 시켜봐요.
예, 되게 해가지고 다시 해보겠습니다.
Yeah, the mitral valve annular disruption.
오른쪽 뷰가 더 잘 보일 것 같은데? 안 보이네. 퍼스널 롱 아까 있지 않았었어요? 퍼스널 롱 앞에 슬라이드에 엄재 선생님 좀 설명을 해주셔요.
initial echocardiography, a little bit might have a prolapse, and in apical 4-chamber view or 3-chamber view, with the next one, with the apical wall, it's almost akinetic, and
Yes.
rest-induced cardiomyopathy.
This basically has a global hypokinesis left ventricle. Septum is moving, but it's not much. But if you look at the mitral valve leaflet, very thickened. This is 22 years old. Is that? Yeah, so young anyway, less than 30 years old.
prolapse 확실해요?
I don't think it's a prolapse. It's maybe
It's permanent.
the annulus is well the disjunction. Motion. Look at the motion.
Next.
This is after 1 weeks. 아, 이거는 보인다.
Alright.
It's fractions of
Yeah, probably 1 week. 1 week later.
Right.
yeah, this is 1 week later.
Mitral valve prolapse is very
Right.
prominent. The function is improved.
Mhm.
You can see the evidence mitral annular disjunction.
Right.
MAD.
Yeah, severe.
Initially, mitral valve prolapse was masked because of apical akinesia.
Okay.
Stress-induced cardiomyopathy.
What is the round shape, the echolucent structure?
Which one?
동그란 거.
Here?
아니, 동그란 거.
그 뒤에 거? 밑에 거 있잖아. 그거.
Maybe.
어?
This.
Descending aorta or
Yes.
coronary sinus?
Descending aorta. That's a descending aorta. Because why I'm saying that? You know? Aorta is a high pressure vessel that does not get compressed by cardiac contraction. Coronary sinus does. So pay attention to that. Even though that could be persistent left ventricular cave or any other abnormality
I
or
think
location.
anterior plate is also shows some billowing.
Yeah.
Well, if you have a posterolateral annular disjunction, you're going to have entire mitral annulus going to be unstable. That's what you typically see.
How's the color Doppler?
Oh, I'm sorry.
What's that?
Mitral regurgitation was mild.
Yeah,
And then,
yeah. It's valve regurgitation is not a predictor of prognosis for the MAD patient. So there's nothing.
Called MAD.
So when we call MAD, it means mitral annular disjunction. That's the term. It's a cause of a sudden death. So you need to learn about that. Go home. You need to study today. That's assignment for the fellows.
What's the echocardiographic definition of MAD?
Uh-oh.
Initially, it was ruled out myocardial disjunction. Finally.
So what is the echocardiographic diagnostic criteria?
Sorry, I actually,
Please share by email. Okay.
I will.
You're seeing right there. You
Yeah.
can discover right now.
Yeah.
What happened during the systole? Take a look. Mitral valve, annulus, posterior. Instead of going down, pulsing upward. It's there. Almost like another sort of circulation pattern. Oh, that's good. So, yeah, even though we are not echocardiographer, but an electrophysiologist at least, I think he should do able to pick up some, mitral valve disjunction, because sometimes echocardiographer or any other imaging people not looking carefully enough to look at that condition. So, I think Dr. Hum has a update about all this issue. So.
Initially, echocardiographer miss.
Yeah, I'm sure this. Yeah, not paying attention carefully.
Yeah,
Yes.
because apical ballooning.
Yes.
Yeah. Apical ballooning made stretching of
Yeah.
mitral valve and put the tenderness. So initial
Right.
echocardiography mitral valve prolapse was not evidence.
Mm-hmm.
That the mitral valve annular disjunction clearly.
But as you know, the mitral regurgitation, mitral prolapse is not required for MAD disease. Okay, so you need to be careful. So when young people come sudden death, you really want to look into that very seriously. Any doubt, any question, all the standard now is MRI. Okay? Because the echo cannot pick up the entire mitral valve plane. Unfortunately, most of them happen in P2 section. So therefore, sometimes echo is very hard to pick up unless you do TE. But I'm not sure guidelines recommend the TE. As far as I remember, MRI is a gold standard. Now CT scan, new CT scans, 124 slicer can see this as well. So, but this is actually, in this case, you see such a severe mat. This is a very severe. You can see almost, dyskinetic, opposite paradoxical motion of that mitral annulus instead of contracting, going backward.
Okay, go on.
So
Okay,
what happened to her?
good. There you go. Okay.
I prepared some article it published in JAC in 2021, mitral annular disjunction of mitral valve collapse and in the mitral valve relapse. Annular disjunction in younger age, largely redundant liquid, bilateral mitral valve collapse. This phenotype is more tend to occur ventricular arrhythmia. So a long-term outcome and clinical arrhythmic events was MAD group. It's more arrhythmic events. Let's see, and overall survival is no difference between groups. So it concludes MAD was independently associated with long-term excess incidence of clinical arrhythmic event. However, within the first 10 years, no group difference in mortality. And in 2023, ESC and 2024, arrhythmic mitral valve collapse, disjunction pathophysiology, and it says we know that MAD is not associated with excess mortality, but associated with excess arrhythmic event. And in arrhythmic event group, we divide three portions: trivial arrhythmia, mild to moderate arrhythmia, and severe arrhythmia. There is group difference. Ventricular arrhythmia are associated with excess mortality. And then here, it's asked, is there really potential cause or just bystander? In MRI, there is a mitral annular disjunction. About 30% with inferior mitral annular disjunction. The high PVC burden and NSVT was occurred in significantly. This is editorial comments. Maybe there is a smoke, then maybe there is a fire. This is a theory. If mitral valve collapse repeatedly, then LG deposit in the papillary muscle and the myocardium. So it can make ventricular arrhythmia, such as PVC with RBP. Imperator T-wave inversion suggests some myocardial disease. So, thank you.
Anybody has any comment to add to it, this business?
Professor, can you tell us the course of the patient after that?
He donated the whole organ.
Oh, yeah.
I remember the patient because I was in the CCU. She never recovered her consciousness because she had seizure and hypoxic brain damage.
Anoxencephalopathy. There's many unsolved issues in the med disease. First of all, we really don't know the true natural history of this business. So my first patient died, but we look at this carefully. They are progressive with the age. So not just mitral valve annulus, it's a whole ventricle, septal motion, and all this is influence the mitral valve disjunction degree. For example, as you get older age, you will see some thickening of the septal muscle catch and so on. So there's a disproportional contraction imbalance between septal and the posterolateral or P2 section, then MAD get worse. Okay. Second, New Zealand guys, now Brisbane, University of Queensland guy, published a series of patients MAD about 2-3 years ago, I believe. And they correlated with the PVC morphology with the posterolateral scarring in MRI. That was pathognomonic. That's still open discussion. There's a patient who suffered cardiac arrest. There's never documented any scar. So I think morphologic influence is one of them. Second is the aging change. Third debate is whether sex difference, whether female, male preponderance. No, there's none, as far as we know. Some people argue that because the female tend to more mitral valve prolapse, therefore they would have a higher incidence of sudden cardiac death. But the study analysis showed that there's not much difference, statistical difference. And again, mitral valve prolapse, not a requirement for the MAD. What is the criteria is that the mitral valve closing plane. So MRI criteria right now, as far as I know, significant to be enough need to be along the mitral annular plane valve motion above the 4 to 5 millimeter beyond. That it is. That's why the gold standard is MRI. Echo, you cannot do that. So it is important to find the mitral valve plane first, and then you measure carefully. Usually, higher the degree of upward motion during the fifth lead, more than 10 millimeter, they're high risk. That's we know so far. But those are very rare, but it's happened. So if you, I think at this point, the only what I can recommend is that you have a suspicion of could be MAD, get MRI done. Okay, do echo, screens, MAD, MRI measure to be sure. That would be the best approach. Between the 7 and 5, we don't know what to do. Nobody knows the policy yet. Now, he added nicely PVC, non-sustained VT morphology coming from posterolateral mitral valve annulus. Think MAD before you try to burn that thing. This is important. So the way I can report to backward from EP standpoint, that's what I can say. But other than that, really, there's not much known. Now they're looking at the genetic issue, morphogenesis issue, all that issue. So I think we don't know much about this disease yet. But certainly sure, the number of cases keep increasing now. I think in the future maybe come. I don't know what the European guideline says about the screening. I think basically history, careful history, suspicion, and syncope, young lady don't without any cause, differential diagnosis should be on this. And then get an echo. So syncope patient evaluation reason for you guys to get an echocardiogram is one of the things look for this. And then next step would be MRI. Okay.
I appreciate Dr. and Dr. Joe sharing this precious case.
Yeah, this is a great case.
I think the suspicion is very important. Even in the international conference, there's some arguments. MAD is underestimated. Some people is overestimated. And there's some debates, the association with mitral valve prolapse and MAD. But still, we don't know the exact pathophysiology, right? Except for make a tethering and changing the myocardial.
Some people have a scar, some people don't have a scar, and some people have, mitral prolapse severe. Other important thing you to know, valve replacement does not prevent a sudden death. I had a patient who had probably MAD, had a mitral valve prolapse. They did surgery, and 7 years later, guy died of sudden death. And then when I went back, looked at it, patient had a frequent PVC. We missed the diagnosis. We thought that maybe valve surgery would fix it. No, guy still dropped that. He was ENT surgeon actually. The guy died. So he's one of my colleagues. Practically just bad news.
And the EP physician's viewpoint, the location of a PVC is most important.
Right.
Can you show the slide one more time? It is a basal posterolateral wall and papillary muscle. And some people says LV summit PVC also related to MAD. I'm not sure it is right or not, but I saw in the international conference. So.
Right. The most characteristic of the AVL. Look at the AVL. Sinus rhythm and the QRS complex. Isn't that paradoxical? Looks bizarre, right? Because you got a biphasic 2-3 and then suddenly you got a reversal proportion of the polarity reversal in the ABL. Very typical, we see. So this is not a typical, let's say, posterior, lateral mitral annular PVC. Normally you see. So to have that parietal skull in the ABL is important. So a lot of people look at the ABL because your D3 is a positive. You see that? Yet the posterior lateral PVC is negative in the ABL dominant. Sometimes we can mislead this as the some conduction system PVC, but it actually is not.
LV 펑션은 회복이 됐어요.
네.
LV 펑션 회복이 됐어요. 그러면 하트도 도네이션 됐어요? 아니겠지 설마.
No. I hope not.
큐. EGM 따로 있어 없어요?
무슨 강의
강의
알겠습니다.